Well, welcome to our webinar. Hello, everyone, and a warm welcome. Today, we delve into a critical issue, ensuring access to essential medicines and vaccines in low and middle-income countries, LMICs. Our goal is to uncover challenges and explore actionable strategies for enhancing global health equity. My name is David Lewinson, and together with Will Checkley, we will be chairing today's session. I am a professor at Oregon Health and Science University. I specialize in tuberculosis and infectious diseases, as well as global child health research. William is a professor at Johns Hopkins University, focusing on global health challenges related to chronic pulmonary disease and critical care. His research is pivotal in shaping health policies and practices worldwide. Our panel today includes the foremost authorities in global health, immunization strategies, and health economics. Their combined expertise in these critical areas offers great insights into our discussions on improving access to essential medications and vaccines in low and middle income countries. Tanya Chernucci will share insights on vaccine distribution and challenges and global vaccine access improvement strategies. Tanya leads the WHO's efforts on immunization, policy, and strategy. With a rich background in health economics, she's dedicated to improving access to health technologies. Philippe Duneton, who is not online yet, will discuss the disparities in TB medication accessibilities and propose potential solutions. Philippe is the executive director of Unitaid, bringing over 25 years of experience in public health, especially in HIV/AIDS, to spearhead global health initiatives. And Job F.N. van Boven will talk about enhancing access to COPD medications, emphasizing cost-effective treatment strategies. An expert in health economics at the University Medical Center in Groningen, Job's research focuses on cost-effective respiratory medication strategies. A few tips. First of all, if you have a question, please type them into the chat box. We've allocated a minimum of 10 minutes at the end of the webinar to answer your questions. And
thank you, David. As your chairs for today, we're here to ensure a smooth and informative session, and we look forward to your participation, and they're excited to explore these vital topics together. So let's get started.
Thank you, chairs. I will get started with the first presentation on understanding market failures for vaccine distribution. Let me share the correct screen. One second. And I will focus on two examples, understanding vaccine distribution. The first is on COVID-19 vaccines, and the second on pneumococcal vaccines. I will actually start with the latter first, giving a little bit of a history on access for PCV, so the conjugate vaccines in low and middle income countries. You know very well that the journey for PCV vaccine started in early 2000 when PCV7 was licensed in the United States of America. And it is in 2009, so already 9 years after that date, that the pneumococcal advanced market commitment was launched. And the target for this innovative mechanism for procurement and funding of vaccines in low-income settings was to enhance research and development, manufacturing, and uptake of vaccines in these countries. The idea of the ANC was really to have a financial commitment backed by 5 donors and supported in implementation by various international organizations. WHO was involved, but also the World Bank, UNICEF were part of the mechanism, as well as the Gavi Alliance. And to have this financial commitment of $1.5 billion back relatively higher price for initial doses of pneumococcal vaccines, so that companies could recoup quickly their investment costs in research and development and capacity scale-up and serve lower-income countries at the same time or soon after investing in high-income countries. And this would reduce the gap in uptake between high-income settings and low-income settings. Now, as of 2023, there were 1.6 billion doses of vaccines that were procured through the advanced market commitments, and this benefited the 73 Gavi countries that were eligible for the mechanism. The capacity for production of these vaccines has increased quite a lot, and the prices have been declining over time. So the initial price that was set, as I said, for incentivizing research and development and capacity scale-up was $7. The long-term price to which companies committed in exchange for that higher price was $3.50. And then over time, that price has come down thanks to efficiencies in presentations, stable demand, and also cheaper manufacturers coming on board. Indeed, there were new presentations that were developed by the incumbents, which were GSK and Pfizer. They shifted to multi-dose vials that were best suited for income settings, and that triggered a lot of product switches in 2017 and 19. And then we had Serum Institute of India join the markets with a 30% cheaper product, even though actually the uptake of these vaccines was much lower than expected. Now, looking forward, the vaccine is widely introduced. There's 166 countries or so that have introduced, and the global coverage is estimated at 60%. Again, the coverage in low-income countries is quite high, thanks also to this initiative. The focus really moving forward with regards to access is supporting countries' forecasting and budgeting, noting that there's a higher and higher share of financing for these vaccines that come from national budgets, around 40% at this point, aligned with the co-financing policies of supporting agencies that see countries chipping in for a higher and higher share of the cost. And also, it's important that we work with countries to undergo an evidence-based assessment of product options. There are more and more products coming online, and to ensure a sustainable price and a sustainable supply, we need to ensure that we diversify the market supply. At the moment, we still have 50% of the market dominated by a single supplier, which is Pfizer, to our knowledge. Now, I would like to also share a few links here with perspectives on the advanced market commitments by both independent evaluations and also experts that have worked on this access mechanism and NGOs on a few points. And I'll mention some considerations from those links. The first is on R&D acceleration. One of the criticism that was raised, and it's important for this webinar and the discussion at the end, is around the ability of the new AMC to actually foster research and development, given that the incumbents, Pfizer and GSK, were already in the market with products that were ultimately purchased, and they received 85% of the AMC incentive. And that the other supplier was already in late stage development. There was also questions raised around the ability of this mechanism to increase capacity to meet demand. The demand was actually very high, thanks also to the work of the consortium of which ensured that the disease burden and the value of the vaccine was well understood. The demand was not met, actually, despite the AMC and the dedication of this subsidy or incentive to scale up capacity by manufacturers who pays the scale up is lower than what's desired, and also what we need to do in legally binding agreements as they retained the oligopoly of the supply, despite, again, this mechanism in place. So there was an allocation of scarce supply based on needs that was managed by the alliance. Similarly, there were questions raised around competition enhancements. Again, entry was brought in until the tail end. On transparency, I think there were comments around the fact that the AMC binded the agencies to share information on price, and that actually triggered a lot of transparency for all the vaccine markets, and this for procurement reviewing agencies, but also some criticism around the lack of sharing of cost information by companies, which, in the view of some, may have led to higher than desired price even for the long run. And finally, some considerations around the lack of technology sharing and capacity increase for developing countries. Now I'll look at the COVID-19 examples to provide other reflections. So the journey here, as you well know, began in 2020, and it's the same year that COVAX was launched as an initiative targeting enhanced research, development, and manufacturing for, in this case, countries of all incomes. So it was really open to any country in the world to participate, the different conditions depending on the income of the countries. And essentially, it put forward a broad array of services from research and development. So for safety-supported vaccines received the EUL, Emergency Use List, by WHO, that are listed here. And there were policy services provided by WHO to the strategic advisory group of experts. There were indemnification and liability agreements set up in the companies. And there were regulatory schemes and collaboration set out between WHO, FDA, EMA, and regulatory agency of the UK, for example, as well as the AVAREX collaboration in Africa. So there was an end-to-end support, and also support of those countries to introduce, develop their plans, and increase their supply chain capacity. All in all, by the end of 2021, COVAX delivered 1 billion doses of vaccines. And if we look at the low-income country settings, 80% of their COVID-19 vaccines were really provided by the COVAX initiative. You see in the graph here the distribution of doses over time, with 2021, as you know, as a sort of struggling year. And then a pick up in 2022, and then an evolution of demand declining as in the rest of the world. Now, again, here, what I've done for the purpose of this webinar is add a couple of links with reflections on COVAX. What you will see is that in the various pieces from WHO, Gavi, NSF, and various other partners, there's some elaboration around the ability of the initiative to meet the target. So that was 2 billion doses by end of 2021, and only 1 million doses were distributed. And you know very much that there was vaccine nationalism, so-called, that essentially prevented COVAX from accessing doses. But also some considerations around the fact that COVAX set a target of 2 billion doses when the world actually consumed 12 billion doses by the end of 2021. And so from that perspective, probably an underestimate of what the world actually needed at the time of a pandemic for a mechanism that was set out to be global in ambition. Also, COVAX suffered from the fact that countries had other procurement channels and really bilateral or regional schemes, such as the one in the European region or even in the African region, the ADAT, were leveraged for countries to procure vaccines. And all in all, COVAX only procured 10%, which is the red portion here in the bars, of vaccines over time. And so ultimately, a small, in global terms, a small influence on the distribution of vaccines, which leads me to the third point around the equitable distribution, where the idea was through an equitable allocation framework to ensure that countries would get equitable access indeed, including based on need, and that was possible within the initiative, but not across the full procurement, given its limited reach. A lot has been said also on COVAX absorption rates in the low and middle income countries, the difficulty of the systems from various perspectives, from the health workforce to available financing at time of need to distribute and really ensure a shot in arms for every vaccine delivered. An alternative view of this is that when the vaccine was finally reaching these countries, Omicron had hit and the demand or perception of need had really gone down. And so that there may be a lot related to that, or also the limited visibility that countries had on which supply they would get. A lot of the supply that ultimately reached these countries was through donation to COVAX rather than the advanced purchase agreements that COVAX had wanted to. And then finally here, again, a point around technological capacity for developing countries. There is a big, strong voice from the developing country vaccine manufacturer network that the supports that went out for research and development and also the advanced purchase agreements were limited for the community of developing country vaccine manufacturers that has been very active on the vaccine space for many years and really benefited new companies that were entering the vaccine space in a disproportionate fashion. So again, some thoughts for everyone to think through as we all work on the access agenda and really try to improve our prospects. I have only a couple more slides on more general reflections from these two examples. One is really on the definition of market failures. So essentially, that's where we all agree that vaccine markets fail to maximize the societal welfare. And this is the case very much in vaccines because of externalities, because of the production structure, risks and returns entails with the vaccine manufacturing that leads to oligopolies and also a lot of incomplete information, particularly in the country's introduction plans or production costs. So, the failure is recognized, and the vaccine community at the global level has been engaging in market shaping to sort of course correct this failure. Nevertheless, what we observe, some reflections from our side, is that while we tweak the market operations by creating incentives to companies and strengthen those incentives, we are fundamentally not changing the paradigm for which vaccine development, manufacturing, pricing, and distribution is largely in the hands of pharmaceutical companies that are bound by shareholders' interests, sometimes not aligned with the global public health need. And that probably this is what requires more work and maybe more courage, more innovation moving forward to really recognize the failure and put forward more of a role of state. That's on sort of the supply side. What we also need to recognize is that there is a big part of the problem that is what's called the demand side. And so ensuring that countries actually purchase vaccines when they are available. This is some data that we're sitting on at WHO on countries' reported shortages for various vaccines. As you see stockouts. And as you see, the stockouts have been sort of dancing around 60 to 80 countries over the past several years that report stockouts for all the vaccines that are listed on the right. And what is interesting is that we started to collect information on the causes of stockouts. And what we see is that shortages and quality issues are a part of the problem, indeed. But there are also procurement delays and funding delays. And these are very much in the hands of countries to ensure that vaccines get sufficient budgets, that those are implemented in a timely fashion, and that procurement processes are strengthened to have access to all the possible supply available, from just having tenders in the English language or requirements that can be met by international companies, particularly those from lower income settings. We have a report that was issued end of 2022, reflecting very much on COVID-19 and the emphasis it gave on the access cause, and that is calling on a changing paradigm with really more investment from governments in vaccine development and implementation, but also more oversight of the manufacturing and distribution process and pricing schemes, as well as international collaboration rules for sharing vaccines equitably that would provide a solution and avoid what we've seen with COVID, but also again with PCV vaccines, improve transparency, and also work on technology transfer in low and middle income country settings. And I would say that there's plenty of action that is taking place, also spurred by the COVID-19 pandemic. There's the pandemic accord that is being discussed currently at the WHO. We have an effort that is called Market Information for Access that we launched several years back at WHO, and it's getting more and more attention with information on all the vaccine procurement for all countries in the world that report to us, and we have almost universal participation. We have the African Vaccine Manufacturing Partnership that was launched in Africa, and a lot of support going to that. And we're working with WTO on various fronts, for example, on harmonizing coding system on tariffs to ensure more access. And I'll close the presentation from my side with the slides for reflection on the TB vaccines with M72, but others also in phase 3 and the spotlight. So late stage pipeline and an opportunity we have here again to engage for access and maybe to learn from past examples and engage in a more innovative fashion. I'll stop here. Thank you, Chair.
So Tanya, thank you so much. That was amazing. And I already have lots of questions for you. But I think what we'll do, and I know that Philippe can't join us today, is turn this over to Job, and I'm probably getting your name wrong, and have you do your presentation, and that'll leave us with about 20 minutes for questions at the end. I think if you have questions, you're supposed to post them in the Q&A box, but if not, I think Will and I have lots of questions for you.
Thank you, David, and thank you also to ATS for the opportunity, and to Will for inviting me for this lecture. I'm Job van Walven. I'm a respiratory pharmacist with a PhD in health economics, working at the University Medical Center in Groningen, the Netherlands, and particular interest in how we can optimize respiratory drug use around the world. One of my roles was a health economic work package lead in the Horizon 2020 program, Fresh Air, focusing on implementation of effective respiratory interventions in low-middle income countries, where we did a lot of field work in Kyrgyzstan, Vietnam, Uganda, and rural Greece. And these are some of the experience I'm also will be sharing in this presentation. But I'm trying to put a presentation together with a very challenging question. So what are the solutions? How can we address the medication availability disparities for COPD in low middle income countries? And of course, this is a multi-million question, but I'm doing my best to give you a few perspectives on this to see how we can bridge the gap. So just as a brief background, We have very good, effective COPD medication. Effectiveness has been shown widely in randomized controlled trials. We have several guidelines that are recommending these medications. So, and in most high-income countries, COPD medication is widely available and is helping to reduce the patient burden. However, in low middle-income countries, the place where the burden of COPD is highest, and between 80 and 90% of deaths due to COPD globally occur in low middle income countries. And that's exactly the place where the availability of COPD medication is lowest. So more understanding of the underlying reasons and potential solutions is needed. And these were the questions I got from the chairs to answer basically in this webinar. So what are the challenges in accessing COPD medications in low middle income countries? Which factors play a role? And what are the strategies for improving medication access? So on the left, you'll see the international gold document for the strategy document for COPD treatment. And this is in particular a picture of the pharmacologic treatment. And as you can see, bronchodilators are basically required in each and every severity, being it group A, group B, or group E. And in group E, with higher blood eosinophils, also inhaled corticosteroids might be needed. So then you say, okay, this sounds feasible, not too many medicines that are required. And let's take a look then at the essential medicines list of the WHO. And this looks quite promising. Most of them are there. We see a LAMA, tiotropium isn't there. We see short-acting bronchodilators, salbutamol, ipratropium. And we also see an ICS, a LABA combination. So basically, we should be able to treat COPD if we adhere to our essential medicines list. However, these are the results of a recent systematic review on the availability of respiratory medication covering asthma as well as COPD. And in this systematic review led by Marie Stolbrink from Liverpool University, Europe, identified with the team 29 studies covering 60 LMIC. And very disappointing, only 10% of countries met the 80% availability target for the short-acting beta agonist, 6% for inhaled corticosteroids, and 0 for the ICS LABA combination inhalers. For the LAMA, the long-acting muscarinic antagonists, it ranged between 2 and 13% in the two countries they found studies on. During the Fresh Air project, we also looked at the availability and use of respiratory medication in COPD patients in Kyrgyzstan. And there we found actually similar numbers, with only 1% of patients having access to a LAMA and 6.8% having access to a LABA out of the 264 patients that we surveyed in two places across the country, one a bit more urban area and one more rural area. So what are the underlying reasons and challenges for why don't we have these available in these countries? And maybe a very easy one, or maybe a prerequisite to receive medication, is first to get the diagnosis of COPD. And Will Checkley, one of our chairs, did a very nice study within the GECKO project. We looked at this with a case finding study for COPD in 1,000 people in Nepal, Uganda, and Peru. And as you can see in the main results, 95% of the cases that were found by spirometry were previously undiagnosed, and only 4.5% received at least a SABA, so a short-acting beta agonist. And let's say the maintenance medications were not used at all most of the times. And this is a broader issue, not in just these three countries. In most low middle income countries, there's a very low number of medical specialists. I remember also when I was in Uganda, by that time, there were like 5 pulmonologists for the complete country. It's maybe now it's a little bit more, but also a low number of diagnostic tools. So in 2019, peak flow or spirometry was only available in 45% of primary care facilities, according to the WHO. And if you compare this with, for example, blood glucose measurements for diabetes, this was twice as many. So I think there's a long way to go in making sure there's access to specialists, having the and be able to make the diagnosis with the appropriate equipment. So this is the first part. So, but even when COPD medication would be available, there's still financial constraints, because there's now a very good statement also in the updated GOLD guidelines of 2024 that's clearly stating many inhalers, especially the LABA/LAMA and the triple combinations, are still branded and few affordable generics are available. And if you then look at the affordability of medicines for COPD, that was also addressed in the same systematic review by Marie Stolbrink in the Lancet Global Health last year, the availability or the affordability is also very low. If you look at the definition of the WHO, stating a medicine is affordable if 1 month of treatment costs less than 1 day's wage of the lowest paid unskilled government worker. And if you then look at the 10 studies that were identified in the systematic review, for SABA, this ranged between 1 to 4 days' wages. For ICS, 2 to 7. For ICS LABA, at least 6. And for LAMA, it ranged from 4 until almost 100 days of wage of income in the Gambia, for example. And also training and adherence to guidelines remain important, because even in some countries where equipment might be available, spirometry is not always performed. It was implemented in less than 1/4 of the population with COPD, and self-reported adherence to guidelines was therefore very low. Talking about guidelines, also during the Fresh Air project, together with some of the GECKO collaborators as well, we did a systematic review on the availability of national guidelines for COPD, which in our view are critical to have the right treatments being recommended that are fit for the local environment, including affordable medicines. And as you can see in this map, in blue are the high-income countries, in red, low-income countries, with the darker colors indicating availability and the lighter colors indicating no availability. Guidelines did not cover only 0.02 billion people living in high-income countries, so only 1.9% of the high-income population didn't have a nationally tailored guideline for COPD available, whereas in low middle income countries, including almost 2 billion people, 30% of the countries were without guidelines. As you can see, this is mostly Africa and some part of South America and a few areas in Southeast Asia as well. Then there's another issue that we were briefly discussed, of course, by Tanya in the talk about vaccines, and that's the IP and supply chain issues. Especially, these are more system challenges that might be difficult to solve by us as a community of respiratory clinicians and researchers. But these are very important and needs to be done correctly, because there's basically two models that you can think of with IP. So there's like charitable contributions from high-income countries to low and middle-income countries that basically donate medication or vaccines to the countries that produce them. And this is the model still preferred by the World Bank, as it reserves intellectual property right while ensuring some extent of access, I would say. The other option would be, of course, that the World Trade Organization would provide a waiver to transfer technology and enable domestic production. Of course, this model would challenge the intellectual property rights, and but it's deemed essential, of course, to prevent. But it's deemed to prevent actable access to medicines. Then a third issue are the weak internal supply chains in some low middle income countries, and this includes issues like regulatory approval pathways, surveillance, cold chain, and delivery capacities. And Delivery also includes the different areas or facilities within a country. So it could be hospitals versus pharmacies, but especially also how to get medicines from urban areas where they commonly arrive to more rural, remote areas in public and private places. So there's a million-dollar question, I'd say, how to improve this situation. That was for me, of course, the most challenging part of this this webinar. What solutions do we have available? And fortunately, very recently also a kind of an online brainstorm session or roundtable group discussion has been held with 58 key stakeholders, including patients, healthcare practitioners, members from national, international respiratory organizations, industry, as well as WHO, and they created this very nice roadmap, as you can see on the right of the screen. So the main barriers they identified, and I think we touched upon a few, is the low awareness of chronic respiratory diseases in some of the low middle income countries. And a small anecdote is, I remember when being in Uganda, some of the local people said, yeah, we basically have two diagnoses. You have TB or TB negative, and that's it. If you're coughing or short of breath, TB negative, you're okay. And nobody would think of, oh, it could also be COPD, for example. So this is a bit of a part about awareness. Also about limited data. So for most governments and some of clinicians locally, they are not aware of the burden of chronic respiratory diseases, but also the available treatments. Ineffective procurement and distribution networks. This has been mentioned before for the vaccines, and poor communication. So what are the needs of these patients? And in the roadmap, they basically, and I use this roadmap for my next few slides to zoom in on a few, is according to this panel the way forward. So create more awareness, focus on clinical guidance, address the supply chain, collect data, make sure communications and messages are targeted correctly, and involve the World Health Organization. And these are here today. That's very good already. But first, let's look at the issue of awareness. So here, it's where it should start with. So in my view, also to create solutions, it should be co-created. So we should align awareness and prioritize access to COPD medication with broader sustainable development goals. But I think maybe even more important, the national governmental goals. So if a government wants to reduce hospital admissions, make their population more fit, more productive during at work, we should say access to medicines, to COPD medicines, is helping you to achieve these national goals, and the politicians can say, okay, we do this because it helps our own national goals, not just for COPD. Raising awareness should also be an international effort, and something that the ATS and other respiratory partners like International Respiratory Coalition that has been launched, that's particularly focusing on raising awareness of respiratory diseases. That would provide a good lobby to global and national policymakers. Then the clinical guidance. I showed you this review we performed on the availability of national COPD guidelines. But what's maybe even more interesting is that accompanying our review, a very nice editorial was written by Eddie Lang et al. And in this editorial, 5 very important messages, and I've summarized them on this slide, were there to make us aware of the importance of LMIC specific guidelines for COPD. So they should focus more on vulnerable populations. They should be very inclusive. So many of our RCTs that I mentioned are performed in high income countries, and we not sure if they will do the same in certain low middle income countries, or maybe the causes of COPD might be slightly different. Guidelines should recommend treatments that are accessible and affordable. in their countries. Equity should be addressed. And they should be really, and that's, I think it's the main message also from our review, they should be tailored to the setting, and make sure they go beyond just endorsement and reproduction of guidance developed elsewhere. So this is a few. And this is one of the, for me, more difficult ones, the supply chain. It was mentioned before, and it's difficult for us, maybe as clinicians, researchers, to impact, because you would need political influence, I think, for real change in this area. However, what we can do is education and evidence-based medicine and on cost effectiveness, and that may be a task of our community. What we could do. And I looked a bit more into the supply chains, and there's a very recent paper that just came out, February. Actually, the publication will be in the February issue of the Journal of Health Policy and Law, and it's been written by Ashley Fox from the State University of New York, and it gives a very interesting overview if you're interested in this topic, not just for COPD, but it gives a very nice overview of how supply chains impact the availability of vaccines and essential medicines. And I summarized one of the tables here on this slide. So she looked back into early periods of the 70s and 80s, where the reform of the supply chain was really focusing on the establishment of central medical stores and essential medicines programs. And in several low-middle-income countries, there was reverse engineering. So they replicated some of the medicines that were available in high-income countries, and they ignored patents for domestic production. The approach here was to address market failures in pricing, so keep affordability and rationalize the supply. In the 90s and a bit of the zeros, the World Trade Organization and global TRIPS, so trade-related intellectual property rights, were introduced. So this actually reduced the ability to disregard patents. At the same time, there was more privatizing of the central medical stores that were on the central level buying medicines in low-middle income countries, and some user fees or co-payments were introduced. The goal of that strategy was to address the state failures, because in the end, these central medical stores were not very efficient, and still there was large numbers of stockouts, and that happened for some part because of corruption, nepotism, and low public sector performance. So what also happened is that there was the introduction of parallel private systems by that time. So there were private clinics and public clinics at that time were introduced, and that continued in the zeros, the early 2000s. So, but there we also saw combinations of private-public product partnerships. But at the same time, we saw the proliferation of new drugs that are more expensive, but also more bulky to distribute. So the goal here was then to marry the market forces with the social function of the state. And efforts were starting with the central medical stores to make them a little bit more autonomous. What about any new solutions? And that's following from these parts. And also, Ashley Fox is providing some interesting ways forward on this part here in the middle, basically, of the supply chain, especially a part about marketing registration, selection, pricing, and the procurement and supply part in particular. So the statement here of this paper was that autonomization of the supply chain governance structure might result in more motivated employees. And one of the problems is that they can become more independent. However, this would still not make up for the underfunding, and accountability mechanisms should be put in place as well. One of the other things that should be addressed is the distribution challenge, especially the last mile delivery part. So optimizing the transport from central parts of a country to the more hard to reach local rural areas. Another recommendation was to really create more pockets of effectiveness by strengthening the human capital and the resource management of people, especially working in this supply chain. But what about IP? This is another elephant in the room, basically, that we just mentioned. And for this, very recently, the European Commission has put forward some ideas that could maybe challenge the way we work with intellectual property rights. So they of course, they acknowledge that pharmaceutical innovation has two fundamental conditions. There should be the ability to develop the innovative drugs. On the other hand, there should be the possibility for patients to access them. And to reward this innovation, intellectual property rights are in place. However, at the same time, this creates a barrier. So there's a kind of discrepancy between these two conditions. And then one of the issues with access is that individual countries or member states for the European Commission are responsible for the pricing and reimbursement, while the medicines itself, and the approvals go on, for example, a European level. But by this, let's say, state or national, or sometimes even health plan differences in reimbursement and pricing, this will lead to significant disparities in prices and timing of access across countries. So one of the propositions they make is that we should maybe think of a bit more, that they say EU, but I translate this maybe to global in this case, price for medicines, while price is paid by the member states to the EU or global fund, take into account the ability to pay. So it's kind of a global health insurance, it seems like they are proposing, but it would mean in the end faster access to all medicines for all. And the benefit for the pharmaceutical industry is that they don't need to go through each and every national procedure to get access, to get reimbursement for their medicine, but they would get immediate access and immediate reimbursement for all countries. Another option, and that would challenge the IP again, is to adjust the current incentives, and that would limit access profits. So lower the prices when more public funds have been put into the development, or reduce the duration of existing exclusivities. So these are very high level ideas that have been put up, and of course it's not something we can immediately influence. So is there something we as Respiratory Society members can do? And that might be data. We're good at data. We're good at collecting data, putting studies together, and this is maybe something we could put more effort in. And during the Fresh Air program, for example, we really did a large data study in over 1,000 patients, asking, in particular on this right part, so how are chronic respiratory diseases impacting your ability to work, being absent from work, being present at work with still issues, and being overall impaired in your work as well as your activities. And this could send strong messages to local governments in how a disease is impacting the workforce of their country, and therefore might urge them more to put more efforts in making effective medicines available for these patients in their country. Then finally, the World Health Organization was one of the solutions, and I'm very sure COPD is on the radar of the WHO. And again, in their 72nd World Health Assembly, improving equitable access to medicines was on the agenda, and also 5 pillars were formulated, including pillars that focus on research and development, that improve access to the products, management of intellectual property, evidence-based selection of medicines, affordable pricing, but also procurement and supply chain management are on in this list. And then when they are available, appropriate prescribing, dispensing, and rational use. So I think this roadmap is very clear, and we as a community, I think, should really think, what can we do, and for what part do we need politics and larger health organizations? So I hope this gives you a little bit of insight into the issues and some of the potential solutions. If you have any questions, here's my email address. And if you're interested in reading some of the studies that I mentioned, here's the list of references that you can check out. So thank you very much again, and we're happy to take any of your questions.
Well, thank you guys so much. Those were both fantastic presentations. And now I'm not that sad that we only had 2 presenters. So maybe I could take the liberty of asking. You guys brought so many interesting questions up. And Tanya, I'm thrilled that you brought up TB as your final slide. And there's lots of, I mean, and you guys both, there's so many things to think about. I guess my first question about vaccines is, and this, I think this is very relevant to TB, but also HPV, and that most of the modeling for TB would show that it's going to need to be an adolescent vaccine, which is really different than the childhood vaccines that we've so successfully employed. So kind of, given all your experience now with COVID, which is an adult vaccination strategy, how do we either integrate our thoughts about vaccines in adolescents to the more global healthcare system? And then how do we get community engagement early on in such a way that we would hope that some of that skepticism would be maybe mitigated? I mean, there's so many, you brought up so many interesting questions. So maybe starting there. And then I think that would at least leave us a couple minutes, Joe, for you as well, because you guys both gave such thoughtful presentations.
David, thanks for that question. And again, thanks for inviting me to this webinar. It's very important topics. I'm glad that they're getting a lot of attention. On the platform, you're correct on TB. And as you've said, we've come through that experience with the HPV vaccine. I think the first consideration I make is that the community, I would say, has recognized that we need a life course approach to vaccination. And so I think we've moved away from the idea that childhood vaccines are the only challenge or target ahead of us. So I think that's I would put that sort of behind to say that that's probably endorsed. Actually, it is endorsed through the Immunization Agenda 2030 by all member states at the World Health Assembly. So I think the target is there, the ambition is there, the vision is there. Now, that doesn't mean that there are no challenges, and we face them with the HPV vaccine. Is still quite low in coverage, in part for some of the issues that we've discussed here around supply and pricing and market dynamics, but in part also because of the target population, as you're saying, and the lack of a platform for delivery. There's been different experiences in countries leveraging the school system, but also other standard delivery methods. One of the things that we wrote an article recently about HPV and that could be leveraged for TB as well is leveraging the partnership beyond the immunization community to reach these different target populations. And so for HPV, there was really a wide outreach by the immunization community to the cancer, communicable diseases, sexual reproductive health groups, women associations, that really was helpful in enhancing ability of countries to reach girls, because it's girls that have been targeted primarily, particularly in lower income settings. Of course, the challenges remain also related to cost of delivery, precisely because those platforms need to be developed. But I'll leave you with a consideration that there's also a pipeline of additional vaccines that will come. You mentioned TB as being one. And so over time, some of these barriers will be addressed in a more cost-effective fashion, precisely for the ability to go farther with this platform beyond a single antigen. So I'll leave it at that and leave some space to John.
No, thank you. And Will, did you want to? I bet you have lots of questions for Joe.
Well, I wanted to just do a question first for Tanya also on vaccines, specifically pneumococcus. In pneumococcus, we focus a lot on kids, make sure that they get those PCV doses early on. How about adults? What do we know about PCV coverage in adults 65 and over, or those that have kind of a risk factor that could contribute to their increased risk of pneumococcal, and how, what is that coverage, and are there different aspects of failure, not, whether it's market or public health, to be able to reach this population?
So William, thanks for the question. I think the answer is, again, probably similar. There's a question first around the supply. We've actually looked into that a couple of years back, whether supply would be an obstacle to introducing PCV vaccines in adult populations. And I think, as with everything, if the planning is there and sufficient incentives are put in place, that wouldn't really be a barrier, particularly with, as I said, a plethora of pipeline producers that are coming on board. So it's really here again about setting a specific target and ensuring that the financing procurement are there. Then we go back to the question of David on the platforms, right? And ensuring that we leverage the experience, for example, we had with COVID, to ensure that their platforms are built where they don't exist, or strengthened where they're weak, for adults immunization, and in this case PCV. One value proposition for adult vaccination that countries may think about when they actually have to balance the use of the next $1 of scarce resources on immunization investments, or across their health agenda, is the fact that reaching adolescents and adults and having these platforms developed at peacetime would then be helpful at the time of an outbreak or a pandemic, like we faced with COVID. And so that's one angle that we put forward to countries to consider. But again, resources are scarce, and there's vaccines that are really having a very high return on investment that still have not been introduced in countries. Think of the malaria challenge that the African continent, for example, has. And so, it's a matter of prioritization, and that's a big challenge that countries have themselves right now.
And Will, do you mind if I ask Joe a question?
Sure, and I'll follow you after you.
Yeah, so I was super intrigued that you brought up IP as kind of a central issue. And I've thought a lot about this as well for vaccines, but also other things, that we, at least in the US, we have a system that incentivizes derivatives as opposed to innovation. And I'm just wondering, you've obviously thought a lot about this, like how would you, if you had your druthers, kind of how would you change the IP system to sort of really motivate either innovation or better distribution? Like how would you, to motivate manufacturers or companies to sort of really address the needs that you outlined?
Yeah, that's a very challenging question. But indeed, there should be an incentive for the manufacturer, while at the same time making sure everybody has access. And this balance is very difficult to reach. But at the moment, I think the scale is not really in balance because of the large shortages in some areas. So this would mean we either and then that was being one of the options that the European Commission has recently explored. Basically, should we have a more global access to innovation? So it would the benefit and then shorten the IP exclusivity maybe. So if you shorten that part, you take money of the innovator, but if you increase access, you give them more. So it's basically a matter of a lot of money for a lot of income return on investment from a few patients that you're supplying your medicines to, or a little bit lower uh, uh, profit for a large number of people that you also earlier reach. So I would say lower the length of the IP, but increase the access speed to the innovation.
Loaded question for you. See what you think. What are your perspectives on this? So we talk about market failures or failures to reach our populations of medicines. When I read the World Health Organization recommendations and I look at the World Health Assembly for asthma and COPD, it says, oh, give them inhaled bronchodilators and oral steroids if they need it. But there's zero mention of inhaled corticosteroids, which are, I consider, mainstays of therapy for both asthma and COPD. So how do we address this, and what kind of what kind of advocacy we need to do to make a change, and could this have an impact on a greater outreach in making inhaled corticosteroids available?
Yeah, and I agree fully with you that especially for asthma, it's critical to have the ICS, the inhaled corticosteroids, available. For COPD, you of course know that it's a smaller group that might benefit. On the other hand, we see on the essential medicines list there are quite some inhaled corticosteroids being put on there, and these are available as generics also, most of them. So this is a good thing. So I'm not sure then why there would be a differential price still between the SABA and an ICS at some point. If, of course, the SABA is even more competition and more generics, but I would say these are now coming very close to each other in pricing. And then I wonder if it's a matter of local knowledge and guidelines and procurement of the right medicines in countries that we should probably raise more awareness on.
Thank you, Yo. David, we have one question from the audience.
I see
and
that.
we can wrap up with that.
Yeah, actually, two questions from the same person, Barbara Stewart. But her first question was about vaccines, and she's asking, she says, what about patients both young and old who don't respond to vaccines? That's a broad question. And then her second question was, which is true in the US, quite a few people with and without insurance, but few can afford required medications. But maybe, I know we're kind of going to run out of time, but maybe kind of tackling this question of patients who don't respond to vaccines, and how do we think about that from I guess from a global perspective.
So, Barbara, thanks for the question. I wouldn't be the most qualified personnel here to respond to a specific question. We do have guidance on our website as WHO, so I'm happy to point you to that. And if other panelists or the chairs are not request, I'll ask you to look into it.
Yeah, it's a challenging question, and gets into things that could be even more expensive than vaccines. And then on the lack of insurance thing, I love the idea that both of you sort of brought up healthcare as kind of a human right, and I really do support that concept, and I think that sort of highlights for both of these programs sort of better integration with both vaccines, but also access to therapies for COPD and sort of a universal health coverage concept. Okay, I am thinking we should wrap up, you guys. There's one more question now that I can see from Mark Cohen, and he was worried about the quality of the generics for both ICS and SABA, and that maybe that's our last question, Joe, for you to try to tackle, and then we'll kind of wrap up.
Can I briefly say something about that? And that depends if it's, if there's local capacity of manufacturing, of course, but also again the supply chain issue here is very important in how to store it's not only the manufacturing quality, it can also be the storage quality, the transportation quality. Many medicines are not used to being exposed to extreme heat. Dry powder inhalers cannot be exposed to moist, for example. So it's partly manufacturing, but I think there's more even to gain with optimizing the supply chain and storage and distribution for that aspect.
Maybe if I can share on this point, agree with my co-panelist. I would also like to emphasize one of the points he mentioned earlier around regulatory systems in countries, and really they need to strengthen those so that the solution is not move away from generics or technology transfer in fear of quality issues, but rather ensure that there are authorities in also low and income country settings that can verify the safety and quality of both medicines and vaccines.
Fully agree. The regulatory agencies should make proper checks for this.
Well, with that, I would love to thank my co-chair, Will, for calling in from Nepal, and both Tanya and Joe for really fantastic presentations and really trying to tackle what I think is sort of a difficult issue and kind of a key issue in bringing, therapies to the world. So really wonderful. Tanya, I would love to have some more time to talk about malaria with you, but that's probably another hour. So with that, thank you guys so much. This was really wonderful. We will, I know this has been recorded, so we can make sure that it gets distributed widely given all the different time zones. And thank you guys again. And Will, you look chilly there in Nepal.
It is chilly.
Thank you so much.
Thank you.
Bye, you
Bye-bye.
guys.
Bye bye.